audience and my senior faculties. So till now we already discussed about the medical management of the heart failure, including the fourth pillar and the fifth pillar, very cigarette also. But we have seen so many patients remain symptomatic in spite of 5 pillars of the medical therapy. So I will discuss about the device therapy in the heart failure. And as we know that in device therapy, that we know that CRT is always there. So what's new after the CRT? In spite of CRT, so many patients remain symptomatic. So what's new after the CRT? And that I'm going to discuss about cardiac contractility modulation therapy. So we know that heart failure cases are growing day by day nowadays, and it is the major cause of morbidity now. And heart failure is a leading cause of mortality. Usually we divide heart failure in 3 categories: heart failure with the preserved ejection fraction, that is more than 50%, and mid-range ejection fraction, that is 40 to 50%, and heart failure with the reduced ejection fraction, that is less than 40%. So we know that the therapies for heart failure with the reduced ejection fraction is already there. That is the 5 pillars we already discussed. But the problem occurs when patient is there with the mid-range and preserved ejection fraction. So even in the preserved ejection fraction, we have a diuretics as a first class 1A indication, and also SGLT2 inhibitors, and other are class 2B indications. But when we talk about heart failure with preserved ejection fraction, we have very limited medical therapies. So now we have to target about mid-range therapy and preserved ejection fraction. So many patients we have seen who are having the preserved ejection fraction, but still they are very symptomatic and NYHA class 3 or 4. So we know that CRT is already there for them, but the problem happens that CRT is indicated when there is QRS is more than 130 millisecond with NYHA class 2 to 4. So about 60% of patients we have seen who are having the heart failure but have a narrow QRS. So then we get stuck whether we should recommend CRT or not. That candidate does not fit in the CRT criteria. And the patient who fit in the CRT criteria, we put the CRT, and 30% remain symptomatic in spite of CRT. So that category of patient is very problematic, and we often have no answer to their problems. There comes the CCM therapy. And especially when patient is having atrial fibrillation, we are giving CRT, and there is no AV synchronization. That is also remains symptomatic patient. Then we have to put on VVI mode for these patients. So only interventricular synchrony we are able to maintain. So now the CCM cardiac contractility modulation therapy is a new device therapy where we put the 2 pacing leads in the RVOT, and we give the high voltage therapy 7.5 millivolt in the refractory period of the ventricle. So it is usually implanted in the similar way the way we are putting pacemaker or ICD, and the main indication for the CCM is heart failure where CRT is not recommended, that is QRS less than 130 milliseconds, or patient having NYHA class 3 and 4 with the ejection fraction of 25 to 45% who remain symptomatic in spite of guideline directed medical therapy, and even the patient who are having CRT where CRT non-responders are also indication of CCM therapy. So let us first discuss the pathophysiology. The main pathophysiology of the heart failure is regarding the calcium metabolism. So what happens in the heart failure? There is a down regulation of gene related to the calcium cycling, and there is up regulation of the myocardial fetal and stretch response genes, and there is a reduction on the L-type calcium channel activity. All these things lead to progressive ventricular dilatation and eccentric hypertrophy, then later on lead to tissue fibrosis, and electrical and mechanical dyssynchrony is coming. So how the CCM is helping in this? The CCM is the mechanism is multifactorial. So these all the mechanism by which the CCM will help. Main, it is helping. It affects the cellular calcium handling, and it downregulates the fetal gene expression. And the best thing about the CCM therapy is it does not increase the myocardial oxygen demand. So the short-term benefits of CCM is happen by changing the calcium handling of the myocytes, by doing the normal myocardial gene expression, and thus it reverses the LV remodeling, and it increased the activation and duration on opening of the ryanodine receptors. It increased the L-type calcium channels, and it increased the calcium influx into sarcoplasmic reticulum. So ultimately it acts on the calcium handling of the myocytes. They have seen the long-term effects of CCM therapy also by calcium cycling and handling, and by down-regulation of the fetal gene expression, that results in the reverse of the remodeling of the tissue, cardiomyocytes. And even the biopsy has proven this thing, that it reverses the remodeling of the cardiac heart failure. So now let us talk about the evidence of the CCM therapy. So in 2010, the fixed HF trial, where 6-month study was done, and they found that peak oxygen consumption was increased with the CCM therapy. Then later on in 2018, fixed HF5C came, where they studied the patient with the EF of 25 to 45%. 6-month study they followed, and they also found that there is a peak oxygen consumption. Then comes the in 2020 fixed HF5C2, where they used 2 leads in spite of the 3 CCM therapy leads, and then long-term study came CCM-RAG in 2019. So in 2018, the fixed HF5 trial which came. So in this trial, they shown that there is a significant increase in the mean oxygen consumption of the patients, and they compared with the previous 5HF5C study also, and they found there is significant increase in the Minnesota patients living with a heart failure questionnaire, and 6-minute walk test also improved. And they further divided these patients into 2 categories, that is 25 to 35, less than 35% of the ejection fraction and more than 35% of the ejection fraction. And they found that the patients who are having more than 35% of the ejection fraction, they improved better with the CCM therapy. And then finally in 2019, it got the FDA approval after this trial. Then the fixed HF5C2 came. So previously what happened, we are using the 3 leads in the CCM therapy, 1 in the atrial, 2 in the right ventricle. In this trial, they did only use 2 leads, that is only in the 2 leads in the right ventricle, and they absolute the atrial lead, and they found that the results are comparable. And the 15% of their patients were in atrial fibrillation. As we know that if the patient is having atrial fibrillation, the atrial lead has no role, same like CRT. So they found that even in atrial fibrillation patient, they have a comparable results with the 3 leads. So that helps that now 1 lead can be not needed, only 2 leads we can put the CCM therapy. Then this is the long-term therapy, study came, CCM-RAG study, where they studied 3 years, and they found that the patient overall, they compared their results with the Seattle heart failure mortality score system, which predicts the survival in the heart failure patient. And they found that overall patient was comparable with the Seattle heart failure score, but the patient who are having 35 to 45% of EF, there is significant survival benefit. So the maximum benefit of CCM therapy they found is occurring when the ejection fraction is between 35 to 45% of the patients. That is mid-range almost. Let us talk about little the technical consideration of the CCM therapy. In 2019, it is FDA approved, and as I already told that it includes the 2 leads in the RV. So we are inserting 2 leads in the RV, and the first lead act as the ventricular sense lead, and the second lead will act as a local sense lead. And we then give high voltage amplitude, that is 7.5 volt, and for longer duration, that is 20 milliseconds. It's very long duration. And the best thing about this device is it is rechargeable weekly basis, and the maximum longevity is 15 to 20 years. And the CCM therapy we can optimize, we can program according to us, and we are giving CCM therapy between 5 to 12 hours. Maximum 12 hours per day we can give the CCM therapy, and longer duration of giving CCM therapy has not shown any improved outcome. And usually it is inserted in the contralateral sites, because the patient who are having EF less than 35%, either they will have ICD or CRT, any other device. So it's better to put on the contralateral side. If it is already device on the left side, better to put on the right side. And then the 2 leads are put in the septomarginal trabeculation in the inferior portion of the septal RVOT outflow tract. And before making final this CCM therapy, it is best to see we should have a good, excellent sensing thing should be there, because it all act on the sensing of the RV. So we require a best sensing. So already insert a lead where we are getting the maximum RV on the device. So we can set the mode OVO local sense CCM therapy, how it works. So this is how it works. I already told that it has a 2 leads. One is local sense and V sense, and one is local sense. The first lead, the V sense lead, will sense that already QRS started, and then there is a local sense alert window will start. And then when the local sense alert window is a programmable parameter which we can program. And after finishing of the local sense alert window, that local sense CCM delay will start. The second lead in the RVOT will sense local sense, and after that local sense, the local sense CCM delay will start. So if there is any PVC between the local sense alert window, it will not trigger the local sense CCM delay. So the therapy will not be given. So once the second lead also shown that there is a local sense, then there is a local sense CCM delay, that is 3 to 140 millisecond, and after that our device will give the therapy 7.5 volts for 20 milliseconds, and after giving the therapy, there is a balancing phase of 40 milliseconds to avoid any polarization effect. So this is how it gives the therapy, and so this therapy is given in the absolute refractory period of the ventricle. So there is no ventricular depolarization by these things. So this is how it looks in the ECG. If you see any ECG, after second half of the QRS, it will give the therapy, and on ECG it will look like this. And we can program between 5 to 12 hours per day at 1 hour interval according to the clinician, and maximum 12 hours we can give. So this is how device looks, and this is the charging. We can put this patch on the device and we can charge this device, and longevity is 50 to 20 years. And this is previous device where we use 3 leads, one in the RA, one is the RV sense, one is the local sense. And then after new trial, only 2 leads we are putting. And this is how, if the patient is already having the ICD, it is better to put on the contralateral side of the body. So some technical consideration: if the patient having the ICD, the large voltage signal delivered by the CCM can be inappropriately interpreted as a ventricular arrhythmia by ICD. So it is better to keep some distance away from the previous either ICD lead or the pacemaker leads. Similarly, in the pacemaker, it is critical to ensure that the CCM therapy do not inhibit the RV pacing. So before closing the pocket, we should check all these things on the table. And already multiple leads, 2 leads we will put here, and previously if patient is having CRT or pacemaker, already more leads are there, so patient may have a TR. So what is the current status of CCM therapy? It is still in the discussion part in the ESC guidelines and AHA guidelines. So in summary, I can say if the patient is having LBP morphology and the EF is less than 35%, it's better to give first CRT. And if CRT doesn't work, then we can go for CCM therapy. And if there is no LBP morphology and EF is 25 to 35%, it's better to give CCM therapy. And if it is 35 to 55%, still we can give the CCM therapy. Thanks.